everybody, welcome back. For my first time visitors, I hope that you enjoy this discussion. It's quite a special day because it's the first time that I've invited a guest. Today we are discussing bipolar mood disorder, and my friend Professor Piet Oosthuizen is going to assist me so that we can bring all the relevant information to you. Hello Piet, welcome, and we're just going to have a brief introduction, and after that we're going to chat about the features of bipolar mood disorder.
Bipolar mood disorder is one of the major mood disorders in the DSM, which is the psychiatric classification system. Bipolar disorder is then subclassified in various forms, mainly bipolar 1 and bipolar 2 disorder, and also cyclothymia. It differs from major depressive disorder, which is colloquially known as depression, in the sense that people with bipolar disorder have more unstable mood and they experience both manic or hypomanic episodes as well as depressive episodes, as opposed to people with major depressive disorder who have recurrent major depressive episodes.
You mentioned the concepts of mania, hypomania. Could you just give us a brief explanation of what these terms mean?
Mania is a condition of increased energy overactivation of the brain. So when a person has a manic episode, they sleep less, they have more energy, they talk more, their thoughts go faster, and they are often quite impulsive in their thoughts, in their speech, and in their behavior. Hypomania is a lesser form of mania, and the main difference between hypomania and mania is that when you're required to go to hospital or when psychotic symptoms, it is classified as a manic episode as opposed to a hypomanic episode, which does not have these features.
Could you just give us a brief description of what it means to be psychotic?
Say that someone has a psychotic episode, the implication is that this person has lost touch with reality in terms of their perception of reality, as in grandiose delusions, which are most common in people with mania, or in that they experience either auditory or visual or other sensory hallucinations. That is the perception of sensory input that isn't actually there.
With manic depressive illness, we're now talking about bipolar mood disorder. How did this come about? How did this progression happen?
In Krippen's words, a disease of recurrent episodes of mood instability. When the DSM was published in the 1980s, the criteria actually became a lot narrower, in that people had to experience manic episodes and depressive episodes in order to qualify for the diagnosis of what then became bipolar mood disorder. But this is actually a misnomer. Mood instability of bipolar disorder actually represents many different mood states, and not only mania and depression. There are at least 5 different mood states that one should be able to recognize. First up, a normal euthymic mood. That means your mood is normal, and when good things happen you feel good, and when bad things happen you feel bad. Secondly, there are the classic bipolar depressive episodes, and in these episodes people tend to sleep more when they're depressed, their mind feels slowed down, they feel incredibly lethargic and just tired all the time. People often get into bed and lie in bed for days and sometimes weeks on end and do very little. Sometimes during these phases they may also have an increased intake of carbohydrates. The third mood state are the so-called happy highs, or those are the classic euphoric manic episodes where the patient sleeps a lot less, they are euphoric, overly happy, over self-confident, outgoing, very productive sometimes, but also impulsive. That is the classic manic condition as we see it in the movies and is described in many of the textbooks. The more common form of it is the fourth mood state, which is called a dysphoric hypomania or mania. And this is actually the most common presentation of mania. In this state, people are also overactivated, also impulsive, but now their mood is irritable and aggressive, and they feel dysphoric, in other words, that it is an unpleasant mood state. This is the more common form, as I said, and then just to confuse matters, there's a fifth one, which is called a mixed mood state, and that is usually a combination of number 2 and number 4, in other words, of the depressive mood state where the patient feels very lethargic and tired, but at the same time feels agitated and irritable and aggressive. This last one is a very dangerous condition because this is when people do serious harm to themselves by cutting or drinking bottles of alcohol or attempting suicide. When we think about the neurobiology of bipolar disorder, the first step is the genetics. In other words, you can't have bipolar disorder without a genetic predisposition, which you inherit from one or both of your parents. Secondly, this leads to changes in the structure of your brain, where there is a top-down problem. The old part of your brain, where your primitive emotions lie, are controlled by the newer part of your brain, and this is a top-down control system. In some people, this system does not work as well as it should, and therefore the control of emotion, the control of mood and mood swings is not as effective as it is in the majority of people, and therefore you get a condition of mood instability. The neurotransmitters that are involved in this condition is mostly dopamine, and therefore bipolar disorder can have symptoms that are similar to other conditions where there is a problem with dopamine, such as schizophrenia or, more importantly, ADHD.
The DSM, the Diagnostic and Statistical Manual of Mental Disorders, was published. Just give us a brief idea what that was about, and especially what the shortcomings of this document are and what the modern trend in thinking is when we consider bipolar mood disorders.
Nature does not read the DSM, and anything is possible on a wide spectrum of disease presentations. So the DSM is a guideline. It is not a particularly accurate guideline, and the modern thinking around mood disorders is much more of a spectrum approach to this condition. So bipolar 1 disorder does exist, bipolar 2 disorder does exist, cyclothymia does exist, but then bipolar disorder has a very long tail of what is colloquially known as soft bipolar disorder, which is the larger part of the diagnostic category. So how do we know if someone or yourself, if you have bipolar disorder? You won't know unless you have a proper diagnostic evaluation by an appropriately qualified person, therefore a psychologist or a psychiatrist. However, there are certain red flags, things that should alert you to the possibility of bipolar disorder. The most important one being instability of mood. This is at the core of this condition, and people will often say, once they start looking back over their lives, that onset was usually around the age of 14 or 15, around puberty. That's usually when it has its onset. And then it starts with mood fluctuations that are often ascribed to normal teenage issues, but then over time you see that this is more than just normal teenage mood fluctuations, in the sense that the person has severe depressive episodes or severe episodes of hypomania where they don't sleep for days and sometimes weeks on end, or they become severely impulsive and creating havoc for themselves and the people around them, struggling with cognitive function and so forth, and then changing into depressive episodes at other times when they become severely depressed and non-functional. If you are concerned, get into contact with an appropriately qualified professional person who could assess your condition and assess it over time, because it's often a difficult diagnosis to make. Families are often exasperated by this condition because it is very difficult to live with yourself if you have bipolar disorder. It is very difficult to live with a person who suffers with bipolar disorder. Interpersonal relationships are often very difficult to manage because, in a sense, you don't know who you will wake up with tomorrow. The most important thing for the family to do is to help the person get to help. First up, to identify the symptoms and to understand that something is amiss, that there is something going on, that this is not the usual fluctuations of mood that most people experience, and then to get the person to a professional person who can help them diagnose this condition, if it is indeed there. The problem is, of course, always one of stigma. There is a lot of stigma around mental health, and because bipolar disorder has, in a sense, become quite a famous condition that many people in Hollywood claim to suffer from, it has become a label that is often applied to people inappropriately, and therefore many people are resistant to seeking help for this. The most important thing that a family can do to help is to help the person identify that something is wrong, and then to get them to a pre-trained professional person. When we speak about the management of complex medical conditions such as bipolar disorder, it requires a complex, multifaceted approach, and we refer to it as the biopsychosocial approach, which means that it is not purely a condition where you take a pill, it's not merely a condition where you change your behavior, it's not merely a condition where you have psychological intervention. You have to have all of these things. In terms of biological interventions, there are certain medications that are classified as mood stabilizers. This is the group of medications that are used in the management of bipolar disorder, and for the vast majority of people, this is a lifelong management of this condition. The medication, because this is a genetic condition, it's not going to go away, and much like diabetes or asthma, it will wax and wane over your lifetime, and you will need medical intervention over time. However, medication is not the only part of the treatment. There are other very important parts of management, and if you don't adhere to these other parts of treatment, taking your medication alone is not going to be successful. Two of the very important parts of management is lifestyle, and here I refer particularly to your sleeping pattern. It is very important to sleep at the right times of day, to sleep an adequate number of hours, to not sleep too much. And if you wonder how that works, sleep like your mother taught you, go to bed at least an hour before midnight and sleep for 8 hours and then get up, and don't sleep in the day. That is, in a nutshell, how you should sleep. Secondly, you should not do any drugs, and be very careful, in fact, of any chemicals that you put into your body, because there are many chemicals, both legal and illegal, both prescription drugs or over-the-counter drugs, that can affect your mood quite significantly. And if you have bipolar disorder, you should make sure that you know about these and that you and your psychiatrist talk about them. Other lifestyle interventions that are very important include things like exercise, eating healthily, taking the correct supplements, and of course going to psychotherapy to manage your stress and to prevent relapse in the future. Many people have a very negative connotation with a diagnosis of bipolar disorder. However, we are fortunate enough to live in a time when the vast majority of people who have bipolar disorder can live a completely normal life, with a few exceptions in things that you're not supposed to do. But this is true for any person who suffers a chronic condition, whether it be high cholesterol or high blood pressure or asthma or diabetes or HIV. any person who has a diagnosis of a chronic condition has to make certain changes to their lifestyle. This is the same for people with bipolar disorder. And then if you adhere to your treatment, if you follow the lifestyle interventions, your outcome is actually going to be very good. So therefore, it is not a sentence into a very difficult life going forward. In fact, if I look at my patient population, I can tell you that some of the most successful people I've ever met in my life have bipolar disorder.
Like any condition, there's always an upside.
And it brings something to you that very few other people have, and that is creativity. There is a definite relationship between bipolar disorder and creativity that we don't know why that is so, but it is. And therefore, you should take from this disease the positive things that you can get from it and live a healthy life.
Okay, so Piet, thank you very much. This has been incredibly informative. I hope that you, the viewer, have a deeper and fuller perspective, a more informed perspective of what it means to be bipolar and how this condition comes about. And if you have somebody like that in your family, reach out, get them help, and also see what are the things that you as a family can do to make sure that you cope as well as possible. Thank you very much for watching. It's been a pleasure having you. If you enjoyed this discussion, please share, like, and subscribe. The more subscribers we have, the more we can get really important information out there. So, thank you very much for watching. Goodbye and good luck.